partly urologist and partly the other specialty IMA members and everyone, even PGs are also joining. So here audience is everybody. So I told the speaker to have a just report of all the audience as well as I told Madhusudan sir also have an interaction and have a good session regarding this topic.
Okay.
Yes. Good evening, all. So today, this is the first webinar of this year under the presidency of Dr. Srinivas sir. Today I am AMS Karnataka State Chapter's first webinar. It's on overview of management of cancer prostate, a very important topic. And as Dr. Suresh said, it's a topic which will be helpful for the general practitioners, the surgeons, the postgraduates, and also the urologists. So at the outset, I request our Honorary Secretary of IMA KSB, Dr. Karunakar sir, to deliver the prayer and flag salutation.
Thank you, madam. Thank you so much. Good evening, everybody. Myself, Dr. Karunakar, Honorary Secretary, IMA KSB, starting IMA prayer. Bharatiya ವೈದ್ಯಕೀಯ ಪ್ರಾರ್ಥನೆ ಎಲ್ಲರೂ
ಕರುಣಾಕರ್ ಕೇಳಿಸ್ತಾ ಇಲ್ಲ. ಡಿಸ್ಟರ್ಬೆನ್ಸ್ ಕರುಣಾಕರ್.
Not audible.
ಎಲ್ಲರೂ ಆರೋಗ್ಯವಾಗಿರಲಿ, ಎಲ್ಲರೂ ನೋವಿನಿಂದ ಆಸೆ ಆಮಿಷಗಳನ್ನು ಮೀರಿ ಗುಣಪಡಿಸುವವರು. ಅಪರ್ಚುನಿಟಿ ಸರ್ ಕೇಳಿಸ್ತಿಲ್ವಾ? ನಾಟ್ ಆಡಿಬಲ್.
Hear you.
ಈಗ ಕೇಳಿಸ್ತಾ ಉಂಟು ಸರ್.
ಹಲೋ.
Yes sir, yes sir. Yes sir. ಈಗ we can hear sir.
Continue.
Yes sir.
Okay madam. Okay, good evening everybody. With the permission of the chair and honorary chair of the AMS Karnataka State Branch, I take this opportunity to welcome you everybody and start the proceedings with IMA prayer. I'm going to restart the IMA prayer once again. It was everybody. ಭಾರವಾಗಿರಲಿ, ಎಲ್ಲರೂ ಆರೋಗ್ಯವಾಗಿರಲಿ, ಎಲ್ಲರೂ ನೋವಿನಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲರೂ ದುಃಖದಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲ ಆಸೆ ಆಮಿಷಗಳನ್ನು ಮೀರಿ ಗುಣಪಡಿಸುವವರು ನಾವಾಗಲಿ. ಜೈ ಹಿಂದ್, IMA ಚಿರಯವಾಗಲಿ. On this occasion, the first AMS meeting of this year, would like to thank and convey our best wishes to the team. We are at IMA KSB available all the time to support, help and guide you as required. Thank you so much. It's back to you, Dr. Geeta Doppa. Thank you so much.
Yes. Thank you sir. Thank you sir.
Over to you. Thank you so much.
Yes sir. Thank you sir for the IMA prayer. Yes, so I welcome our president, Dr. Srinivas S sir, president of IMA Karnataka State Branch, for this webinar. We wholeheartedly welcome you, sir.
Yes, ma'am.
I welcome Honorary Secretary, IMA Karnataka State Branch, Dr. Karunakar sir, for this program. I welcome Dr. Uttam Mete sir, Professor and Head Urology Department of the prestigious PGI Institute of Medical Research, Chandigarh, for our webinar. Thank you wholeheartedly, sir, for accepting our invitation and being a speaker today. Yes, I welcome our chairperson for today, Dr. Madhusudan Kariganavaru sir, past president of IMA KSB, and sir is also a consultant general surgeon at Chiruguppa. We wholeheartedly welcome you, sir. I welcome the past presidents of IMA KSB. I welcome each and everyone who has joined for the webinar of IMA AMS Karnataka State Chapter. Now, I request Dr. Srinivas sir to address the gathering.
Yes, madam. Thank you, madam, for your welcome speech. And so I'll actually have to tell my thanks to Dr. Geeta Doppa, chairperson, and AMS and our Madhusudan Kariganavaru is also chairperson for today's program, and Dr. Suresh Kagalkar also there, and I'm wholeheartedly welcome our speaker today, Dr. Uttam Mete, and he came from the very well-known center, Chandigarh. It's a very academic institute, and definitely everyone will learn today So everybody eagerly waiting to get see your speech also, and also I have to tell our Padma Prakash and Naz Sheikh Madam is there, and Dr. Girish is there, Dr. Divya is there. So many other this one. I'm very sorry I have not seen anyone here. And definitely Gita the under Gita the will have very good programs now. Suresh Kagalkar also urologist is there. And today our Maksud in Karnoor. So he's on limelight now. He is going to chair the session today. And definitely I wish this program a lot of success, and definitely we'll wait for that. Madhu Sabal, okay, you can take.
Yes. Thank you, sir.
Yeah.
Now I request Dr. Suresh Kagalkar, sir, Honorary Secretary AMS Karnataka State Chapter, to introduce our chairperson, Dr. Madhusudan Kariganaru, sir. Though sir does not require any introduction, but just as a protocol, I just request Dr. Kagalkar, sir, to introduce our honorary chairperson, Dr. Madhusudan, sir.
Thank you, madam, for giving me the opportunity. So I'm happy to having this important program. I welcome all the members as well as all the urology members also for this today's function. So let me introduce Dr. Madhusudan Kariganaru, sir. He's a well-known person. No need having a brief introduction. He's having a lot of CV, having a more than 2 pages. Sir is consultant, sir, general surgeon from the Shiruguppa. He has completed MBBS and MS from the Government Medical College, Ballari. He has got a lot of experience and active member and sportive in all the activity, especially IMA and the ASI, Association of Surgery of India. He has worked as a president of Karnataka State Junior Doctor Association. He was a secretary of IMA KSB. He was the editor of IMA Focus. Sir was a chairman of IMA Building Committee. And also he was a task force member of COVID Committee of the Government of Karnataka. Sir was a DNB board member. And right now, presently, he is a Bylaw Committee member of IMA KSB. As a president of IMA, as a president of Shiruguppa Taluka Kannada Sahitya Parishad, he has got a lot of social activity he has done, especially the awareness program. He has made good first aid program, more than 10,000 students, as well as more than 5,000 teachers. He has conducted many motivational classes of more than 50,000 students in the SSLC students. He has conducted many free health camps in the periphery. And he has introduced through his Shiruguppa branch, IMA Nadige Shalaya Nadikadege, Vaidhyara Kade, Sainikara Kade. It was a wonderful program and it is a well-known program in the IMA. And he has been awarded Bharani Chetan Award, a national award from Delhi. And he has got award from the Medical Achievers National Award in the year 2017 for his doctor as well as social activity. And he has been conferred with the Best President Award in the IMA headquarters in the year 2020. Recently, he got award Community Service National Award by IMA headquarters in the August. With this brief introduction, I welcome Dr. Madhusudan Kariganaru sir as a chairperson. Kindly continue the session and we'll have a lot of discussion about the urology topic. And once again, I welcome all the urology member also for this forum. Thank you, sir.
Yeah, thank you for that introduction, Dr. Suresh Kagalkar. I'm glad that we had been into such a very beautiful academic activities through IMA Karnataka State Bank. Thank you for the introduction. And let me directly go into the subject now. Here with us, Dr. Uttam Mete, who is going to deliver a very important and very variedly presenting disease of the male, that is prostate cancer. It presents with asymptomatic to advanced stage, which needs early detection. And here is Dr. Uttam Mete with us. And I am very fortunate to introduce such a wonderful presenter for the IMA AMS. He completed his training in MS General Surgery and MS Urology from PJ Chandigarh, and he has joined as a faculty in the Department of Urology in PJ Chandigarh. He is actively involved in activities of the Urological Society of India. He has participated in debate, symposium, and delivered many lectures during several conferences and workshops. He is the recipient of many fellowships and awards offered by USI, like GM Park Traveling Fellowship, Member Traveling Fellowship, Teachers Traveling Fellowship, etc. He has published several papers both in international and national journals: laparoscopy, endourology, uro-oncology, renal transplantation, reconstructive surgery, and urolithiasis, which are his main areas of interest. The new passion for robotic surgery has widened his spectrum of expertise in urology. He has demonstrated live surgeries in many conferences and workshops. Currently, he is serving as the professor and head of the Department of Urology in the prestigious Institute PGI Chandigarh. Here is Dr. Uttam Mete, who is going to deliver very interesting topic on CA prostate. Over to you, sir.
Can I just share? Good evening, everybody. First of all, I am grateful to the IMA KSB for giving me this opportunity. Thank you, Mr. Dr. Srinivas, President IMA, Dr. Karunakara, Dr. Honorary Secretary of IMA, and of course, Dr. Geeta Dokpa. I had a chat with her a few days ago, the Chairman IMA, and a special thanks to Dr. Suresh, who actually had invited me for this presentation. I'm really thankful. And of course, Dr. Madhusudan, the current chairpersons. I think with this brief, I can start the proceedings. So, as I have been told that the audience will be urologists and non-urologists. So I have tailor-made the presentation so that it is for everybody. So whenever you feel that it is too lengthy, then you can ask me to stop and then I'll stop it. Okay. So that is overview of management of this thing. So what will be a flow of talk? Talk will be basics of prostate cancer, epidemiology, etiology, and risk factors, clinical presentation, diagnostic evaluation, treatment of different states. Nowadays, we don't take CA prostate as one disease. There are different states of the prostate cancers, and I'll gradually tell what should be the treatment overview. Now, basics of prostate cancer. So can I just this thing here? Okay. So as you all know that it is the second most common cancer in the world, and we really do not have much of Indian data, but from one source I came to know that it is the 5th common cancer in Mumbai and 4th common cancer in mortality. What is happening? Why slide is not moving?
Who is sharing the slide, sir?
I'm sharing the slide, so
Okay.
it should be moved now.
Yes, sir. Yes,
moving.
it's moving, sir.
Okay, now. Okay.
Yes.
So that I have already told, it is the second most common cancer in the world. And we don't have any Indian data, but as per some sources, it is the 4th common cancer in Mumbai. As we know, in PGI, we see more of bladder cancer rather than prostate cancer. But as the awareness amongst the general physicians and general surgeons have increased, people are doing regularly, more or less regularly PSA testing, just like a blood sugar or blood cholesterol level. And we are getting many cases of prostate cancer at the early stage. So, but we are fortunate enough to be the Asians because the incidence is very less amongst Asians. Now, who is likely to develop the prostate cancer? That means who are at risk. Now, there are some unmodifiable risks and modifiable risks. Unmodifiable risk is the age. As you all know, the prostate cancer is the disease of the age. As you age, chances of having a prostate cancer is very high. Family history, genetic history, and race, definitely the African Americans, they are supposed to have increased risk of prostate cancer. Some modifiable risk factors which you can really modify, like metabolic syndrome. And there are several components of the metabolic syndromes, but only few components there are increased risk of developing prostate cancer. Like say, for example, diabetes. Now, diabetes, some people say that metformin, who are taking diabetic patients who are taking metformin, they may be at decreased risk of prostate cancer rather than increased risk, but it has not been proven. Those who are taking cholesterol or statins, most probably there's no correlation, but there's weak correlation with the development of prostate cancer. Surprisingly, the obese patients are not at higher risk. We don't know what is the factor. And dietary factors are there. I'll come again and again, little bit. So as you age, I told you, tend to develop prostate cancer. Now, what about the family history? Now, while talking about family history, I think I should explain three things which is important for students. I don't know whether any student has joined or not. What is a hereditary disease? What is familial, and what is familial syndrome? Hereditary disease means more than 3 cases in the same family, or prostate cancer in 3 successive generations, or more than 2 men diagnosed with prostate cancer less than 55. On the other hand, familial disease means more than 2 first or second degree relatives with PCA on the same side of the pedigree. Now then, what is the difference? Difference is, in a hereditary disease, there will be some genetic abnormality. On the familial prostate cancer, it may not have any genetic abnormality. Only thing, the incidence is high in the same family. So that is the main difference between hereditary and familial cancer. On the other hand, third category is the familial syndromes, such as hereditary breast and ovarian cancer syndrome or Lynch syndrome. There may be some genetic disorders also, and patients who are having all these syndromes are likely to develop prostate cancer. Now, how this information is going to help me for detection or this thing? Now, whenever we talk about the cancer, there is a question of there's a reason for screening. So if you can screen the patient and detect at the early, most probably you can cure the cancer. That's why we should know, as a general physicians, who are the patients who should be screened for prostate cancer, like the patients who has got a family history of prostate cancer or other cancers which are really associated with familial syndrome, like ovarian cancer, breast cancer, colon cancer, they are pancreatic cancer. They also can have the same BRCA2 mutation, and the BRCA2 mutation is there, then patient or the person is likely to develop prostate cancer. Now, race, as you all know, that the Black Americans are at increased risk of prostate cancer. Being an Asian, we are at decreased risk of developing prostate cancer. What about the diet? Many people ask, has there any relationship between the diet and this cancer? Most likely not. Whatever study has been done, there's a very weak correlation or no correlation. And it has been found that among the diets, high alcohol intake, some study says that it is associated with higher mortality rather than higher increased incidence of prostate cancer. Coffee, as you all know, coffee consumption is associated with increased risk of bladder cancer, but the other is true for a prostate cancer. It is associated with reduced risk of prostate cancer. Now, dairy products, fat, most probably no association. There are some studies with the tomatoes, because these tomatoes, they contain a lot of lycopenes. And there's a weak correlation between the prevention of prostate cancer or reduced incidence of prostate cancer with the tomatoes. Any amount of meat, whether it is a red meat or a white meat, whatever meat is there, I think this is associated with increased incidence of prostate cancer. There are a study in Australia which is going on with the garlic. People say that garlic contains selenium, whether it can prevent the prostate cancer or not. So the people used to take a lot of garlics, but at the end of the study, it was found that it is not correlated, or it is not the measure to take for prevention of the prostate cancer. So as per the EAU guidelines, prostate cancer is a major health concern, and it has been found that in a hypogonadal men where you are giving the testosterone supplementation, they are not at risk of prostate cancer. These are common questions which are being asked in the general public, by the patient to the general physicians. And there's no conclusive data exist which could support the specific preventive or dietary measures aimed at reducing the risk of developing prostate cancer. So in a nutshell, most probably we cannot prevent occurrence of a prostate cancer by any dietary modification. So there's no correlation. Only thing what you can do, if you have a genetic factors or if you have a family history, one should go for early screening with the PSA. Now, how does prostate cancer spread in the body? That's what I told. This is a tailor-made for the general surgeons also. So as you all know, it spreads by direct spread and direct to the seminal vesicles. It may be by the lymph nodes, but the commonest spread or the commonest presentation in our country is metastatic disease. It will metastasize mainly to the bones, or it can go to the visceral. So that's why whenever we're talking about it, or the lymph nodes. So whenever we're talking or treating a patient of metastatic prostate cancer, we divide the patient into 3 groups. One group with only bone metastasis, another group with lymph node metastasis, and third group is the visceral metastasis, or fourth is combination of all those 3. But commonest is the bone metastasis. Now, what are the symptoms? That's what I think President of KUA already told, that this is mainly the patients are asymptomatic. He is very right. Most of the time it is asymptomatic patients, but patient can have local symptoms. But before we go to the symptoms, I think as a urologist, I should explain a little bit of how to describe the symptoms of urinary tract. Now, urinary tract is divided into upper tract and a lower tract. In the lower tract contains the bladder, prostate, and urethra. For the lower tract, there are 5 symptoms. Whenever we describe a patient who has come to your clinic with a urology symptoms, they have either LUTS, incontinence, pain, dysuria, hematuria, fever. These are 5 symptoms. Now the LARS has got 7 components. I remember, or everybody remembers, like fun, hiss. F for frequency, R for urgency, N for nocturia, H for hesitancy, I for intermittency, S for slow stream, and S for sensation of incomplete evacuation, the fun hiss. And based on that, actually, whenever your patient has got a LARS has got so many mechanisms. The patient has not come to you with a diagnosis of CF prostate. You are supposed to diagnose. So a patient with a LARS plus incontinence or dysuria and hematuria and fever, you have differential diagnosis. Now, a patient who has come with LARS, you have to see what is the organ of origin of LARS. It may be from the kidney, like a patient has got diabetes insipidus, who is producing a lot of urine, can have a frequency also. A patient who has got a lower ureteric stone also can have frequency, lower ureteric stone. So kidney and ureteric pathology, or it can be pathology from the bladder, prostate, or urethra. What are the bladder pathologies which can produce this LARS? That may be overactive bladder, neurogenic bladder, underactive bladder, bladder stone, bladder cancer, bladder infection, everything. Any pathology related to the bladder will also produce LARS. Second is prostate. What are the common diseases of the prostate which can produce LARS? Either prostatitis, BPH, or prostate cancer. And the urethral pathology, like urethral stricture. So a patient who has come with LARS, you are, as a clinician, supposed to decide what is the organ of origin of these symptoms and what is the underlying pathology. When we describe the LARS, we actually divide it into, see, when a normal person, we are storing the urine and then we are voiding intermittently. So that's why some symptoms will be during the storage phase and some symptoms will be during the voiding phase. And some symptoms we call it a post-micturition phase. That's why I have already described. The fun is basically storage symptoms, and voiding symptoms are hesitancy, intermittency, sensation of incomplete evacuation, and poor stream. Now, when this patient has got LARS, the next step for a physician is to quantify the symptom. To quantify these symptoms, we have different scoring system, but commonly used scoring system is IPSS scoring system. So there are 7 questionnaires and each question has got 5 points, and you develop, and then you divide the patients into 3 groups: mild symptoms, moderate symptom, and more symptoms. Up to 7 is mild, 8 to 19 is moderate, and then after that it is the high symptoms. So when the patient has got LARS, then how we are going to decide or detect whether the patient has got cancer or not. So you have your differential diagnosis in your mind, and you think that this is the origin of these symptoms is prostate. Then you have 3 things in your mind: patient can have BPH, patient can have prostatitis, and patient can have prostate cancer. And all 3 conditions will have similar symptoms in the early phase of the prostate cancer also, and all these diseases will have raised PSA. And that's why it is the duty of the physician to decide which one disease you are treating or dealing with. So for that, you need to do a clinical examination, that is the DRE. So definitely, please put your fingers in the rectum. You will get a lot of information. Apart from the prostate, you get a lot of information about the neurologic evaluation of the patient. So like the anal tone, and then you see the prostate is enlarged or not, whether there is nodularity there or not, or the mucosa is moving or not. So these are the information you can get it. If it is tender, most probably you are dealing with prostatitis. If it's a nodule is there, it may be BPH nodule, it may be cancer nodule, or a non-malignant nodules like tuberculosis or granulomatous inflammation, that also can produce nodule. A prostatic stone also can produce a nodule. So nodule doesn't mean it is cancer. It may be anything. 50-50 chance that patient can have a prostate cancer. That's why clinical examination may be normal. Then you go for a laboratory test or imaging, and then the final judge is a histopathology. That means you have to take a biopsy. Then only you can diagnose prostate cancer. Now, the patient usually they come with a PSA. Now, whenever you're dealing, suppose you don't have any other information about the patient, you have only the PSA report. So how we are going to decide whether this particular patient is having cancer or not? Then you see the extent of the PSA, whether it is less than 4. Now EAU says less than 3, 4 to 10, 10 to 20, or more than 15. Now, less than 3 or less than 4, chances of prostate cancer is very, very low. And that will depend on the digital findings. Suppose a patient has got nodules in the prostate, which is palpable, along with a raised PSA, chances of having prostate cancer to the tune of 50%. When the patient PSA is more than 50, so most probably, unless you are dealing with an acute prostatitis, most probably you are dealing with a patient who has got a metastatic prostate cancer. Now, the most problematic area is 4 to 10. 4 to 10 PSA, you don't know. Only 4 to 10 PSA without any DRE finding or normal DRE finding, 25% chance the patient is having cancer. With a DRE findings, which is positive and there is nodule, 50% chance that patient is having a cancer. So what to do? So next thing is you have to decide. Suppose a patient has come with a PSA alerts and PSA of 4 to 10. Then you have to decide whether you want to go for a biopsy or not to go for a biopsy. As I told, that 50% chance that there is no cancer. So if you keep on doing a biopsy, 50% you are doing overdoing, and biopsy has its own risk. So how to decide whether a given patient will require a biopsy or not? So you have 4 things in your hand. You have a risk calculator. It is available in the online, and you just give all these values and they will tell what is the risk of this patient having cancer or not. Second thing is, rather than only PSA, PSA derivatives can also be taken into account. And with this, not only the PSA, the pro PSA and kallikrein, all these things are combined together to give a prostate health index, PHI or 4K index. If these are high, then most probably this patient needs a biopsy to rule out a cancer. But normally or commonly, we go for free PSA and total PSA. I tell you, most probably this has got no value as of today's practice. Free PSA or total free ratio, it used to be a factor when multiparametric MRI was not there, or PSMA PET-CT was not that popular. So that's why I don't do anything of free PSA or total PSA, and never for follow-up of those patients. So that is more or less out. So for God's sake, don't go for this pre and post total PSA or their ratio, which is not required, to be very frank. Then what you have multiple imaging. You have multiparametric MRI and PSMA PET-CT. What is multiparametric MRI? As the name suggests that there are multiple parameters. Now that means it has got 2 components. One is anatomical component of the MRI. Second is functional component of the MRI. Anatomical component is T1 and T2, but commonly used method is T2. So T2 can give us an idea whether there is a lesion or not. Now, for a layman, what do we see? I know as a surgeon, whether it is urologists or general surgeons, these MRI pictures are not very familiar. We are not familiar with these MRI pictures. But as a layman, what you are seeing in the MRI, gray and black and white picture, or the different types of gray. So you can see the normal prostate peripheral zone is white. Now, if there is some black area, that is called hypointense area, there will be a suspicion of a prostate cancer. Now, whether it is there or not, then you need a functional component. There are 3 functional components. One is diffusion weighted image, and the diffusion weighted image, if there is anything suggestive of prostate cancer, you have to confirm with the ADC values. And after that, you can go for dynamic contrast enhancement. So all these functional components are for the detection of prostate cancer, nothing to do with the staging. So a patient who has already been diagnosed with prostate cancer by biopsy, but he has not undergone local staging by MRI, then you go for only T2 imaging. There's no need for multiparametric, because multiparametric is to suggest whether the patient has got cancer or not. Now, multiparametric MRI also cannot tell us exactly whether this patient needs biopsy or not. So you have to add one more parameter, that is the PSA density. PSA density is the PSA value divided by the volume of the prostate. If the PSA density is less than 0.15 or 0.1, that means most likely this patient is not having any cancer. So rather than a single modality, today's era, there are, whether it is a diagnosis or a treatment, multimodality, multiple parameter you add, and that gives a better sensitivity as well as specificity. So that's why the multiparametric MRI gives a PIRAT scoring, PIRAT 1, 2, 3, 4, 5. PIRAT 1 and 2, chances of having cancer is very low. However, in a PIRAT 2 lesions, if the PSA density is high, they also can have to the tune of 7% prostate cancer. PSA 4 and 5, most likely they have a lot of cancer, so more than 60% if it is a PIRAT 5 lesions. But PSA 3, na ghar ka, na ghat ka. So we don't know whether the patient has got cancer or not. There, PSA density helps us to decide whether we should go for a biopsy or not. Third modality of imaging is PSMA PET scan. What is PSMA? PSA and PSMA is not same. PSMA is a glycoprotein. This glycoprotein has got 3 components, as you can see in this left side figure. It has got an extracellular component, transmembrane component, and intercellular or cytoplasmic component. This extracellular region acts as an antigen. So what you do, you develop an antibody against this component and tag that antibody with a radionuclide that will emit some radiation. So if the cancer cell is there, they are going to get attached, and they are going to emit some radiation which will be picked up. So that is a PSMA PET scan. So PSMA PET scan can be used for a diagnostic purpose, for therapeutic purpose, theranostical later on. But this PSMA, that's a PSA is organ specific prostate. It is not disease specific. It cannot differentiate whether patient has got prostatitis, BPH, or prostate cancer. All 3 conditions give rise to PSA. But PSMA is not organ specific. It can be there in other organs also, like duodenal epithelial cells, proximal renal tubule, or salivary glands. That's why when you do a PSMA PET scan, you can see the salivary glands are there. There are black spots. high uptake of the PSMA. It is definitely in the kidneys, and then it can be there in the proximal renal tubules also and salivary glands. So these are the normal things. That's you have to remember that is the job of the nuclear physicist. Okay. Now after that, so a patient has come with a PSA, borderline PSA 4 to 10, and clinically there's no nodule. So what do you want to do? So you want to go for a biopsy to prove that the patient has got cancer or not. Now the biopsy can be done by TRUS guidance or MRI targeted biopsy or PET guided biopsy. PET guided biopsy is not routinely. This is not the first step. First step is TRUS guided biopsy. Second, suppose the patient biopsy has been negative and still there is a strong suspicion of prostate cancer, then most probably you have to go for a MRI guided biopsy or a PET guided biopsy. PET guided biopsy facility is not available everywhere in India. In our institute, we have a facility for PET guided biopsy, and here detection rate has become more actually, where it was negative by TRUS guided biopsy and it has come positive with PET guided biopsy when you have a strong suspicion of cancer. And before biopsy, definitely just because it's just 40 minutes talk, so I'll just go briefly. So you have to give one thing, antibiotics. For any biopsy, transrectal biopsy, you have to go for an antibiotics, and definitely you are going to stop that anticoagulants or antiplatelet for 7 days. And there are complications like bleeding and infection, sepsis. Now, why you do want to go for what you want to looking for in the biopsy? The biopsy will give the microscopic diagnosis, and what we do, we go for a Gleason scoring. What is this Gleason scoring of the prostate cancer? See, in any cancer diagnosis, histopathologists see for individual cells, whether the nuclear cytoplasmic ratio is altered or not, what is the behavior of the nucleus, what is the behavior of the nucleolus, everything. But this is a cancer where individual cells are not being considered. Here, the groups of cells are being considered, like whether they are forming glands or not. If they are forming well uniform glands and small, then it is called a grade 1. There is more space between the glands, and some stroma is there, grade 2. Grade 3 is infiltration of cells from glands and margins. And if cribriform pattern is there, that is grade 4. And lack of glands or sheets of cells, this is grade 5. This is a Gleason scoring, Gleason's grading. So Gleason's grading is not, again I'm repeating it, it is not based on individual cells. It is based on the gland formation or not. Now, there is some problem with this. Now, what usually we do, we see the primary Gleason's pattern and the secondary Gleason pattern, and then we add the together to go for a Gleason scoring. So say for example, a patient has got primary and secondary 3 plus 3. It is called 6. But 6 to a patient, 6 out of 10 looks very high, but it is not actually that aggressive. That's why the concept of ISUP grade has come, and they have divided the patients or pathology into 5 grades, ISUP grades. 2 to 6 is low grade 1. Grade 2 is 3 plus 4 and 4 plus 3. Why? 3 plus 4 is also 7, 4 plus 3 is also 7. So it depends on how much component of 4 is there. If the primary pattern is 4, that means these patients needs actually an active treatment rather than active surveillance. So I'll come later on. So that's why this is the difference between Gleason score and ISUP grade. So nowadays we are using ISUP grade. Now, how do you stage this prostate cancer? If it is related, confined to the prostate or not, this is stage 1. If it has gone beyond the prostate, that is you can see the seminal vesicles, this is a T3 disease, and T4, it has gone into the pelvic side wall. And of course, lymph node status and metastatic status, I had already told for the metastasis, M1A, M1B, and M1C. M1A is non-regional lymph nodes. That means the lymph nodes which has gone beyond the pelvis. The non-regional lymph nodes are M1A. If you have M1B, means bones metastasis, and M1C is visceral metastasis. So this is the TNM classification. Now, as of today's era, we don't treat based on TNM staging. We go, see, in a journey of a patient of prostate cancer, we develop into different states, like localized disease, locally advanced disease, PSA recurrence, metastatic prostate cancer, and castrate-resistant prostate cancer. We call it different states. The treatment of different states will be different, and rather than only TNM staging. That is the main difference from other cancer. Now, as we go through the history or treatment of prostate cancer, everywhere, every stage, we go for a risk stratification. For a localized disease also, we have to go for a risk stratification. So, and it is divided into different risks based on the PSA, the Gleason score, and this clinical staging. Here lies the problem. Clinically, what you are going to see, you are putting the finger in the rectum and see whether the nodule is there or not, and do the staging system. So other systems are like if you do the MRI for that particular patient, may have a higher stage, but that is not included in the normal grading or clinical staging system. Clinical staging is based on your finger only. So T stage. And then you have a GS or Gleason scoring and PSA. If PSA is less than 10, GS is less than 7, and CT 1 or 2A, then it is in the low risk. All three should be there. Intermediate risk, it is 10 to 20, and you can see intermediate is 10 to 20, and GS is 7, or grade 2 or 3 is there, or T2A or B. So that means any patient, we put a finger, no nodule is palpable, he is T1. Any patient, you put a finger, nodule is palpable, it may be T2 or a T3. T2 means if one nodule is there, half the lobe, then it is T2A. If it is more than half the lobe, it is T2B. And if both the lobes are involved, bilateral disease, it is T2C. And what about the T3? T3 is EPE and SVI, extraprostatic extension and seminal vesicle invasion. This is called T3, A and B. And of course, T4, if the bladder neck is involved, if the rectum is involved, external sphincter is involved. Sorry, bladder neck involvement microscopic is not, this is T3. So external sphincter is involved, the rectum is involved, or lateral pelvic wall is involved, it's a T4 disease. So based on this, we divide the patients, whether you are dealing with a localized prostate cancer or a locally advanced prostate cancer or a metastatic prostate cancer. Locally advanced means the prostate cancer has gone beyond the prostate. So there is EPE and SVI minimum. Okay. Now localized prostate cancer is divided into 3 risk categories because the treatment will be different for different risk categories. For a low risk patient, so what are the, so before I go for a treatment, so I just want to say what has changed in the last 75 years. In the last 75 years, spectrum of the disease has changed. Less number of presenting as M1. Even in India also, I still remember when I was a resident, we used to get a lot of metastatic disease, but nowadays we are getting a lot of early stage disease or locally advanced disease rather than metastatic disease. Then ISUP grade group has been introduced, and PSMA PET scan definitely has come, and that has created a problem for us also, because normal staging system in Western countries, it is by bone scan and CT scan. But if you do the PET scan in the same patient, it will show more metastasis. Now, how you are going to do how you are going to treat those patients? Nobody knows. There is a controversy. Not only that, and then survival has improved. Normally, a patient will ask you, so if you have a metastatic disease, what is my median survival? Maybe people used to live for about 3 years. The day you have diagnosed metastatic CA prostate, earlier the patient used to live for 3 years. But now with this development of so many drugs, it has been improved and it has become 6 years or 5 years. For CRPC, I mean castrate resistant prostate cancer, it used to be 1.5 years. Now it is going to be about 3 months. So it has improved. So you can see the normal survival, 5-year survival. The patient, as he goes through this journey of localized to locally advanced to metastatic disease and CRPC, the 5-year survival is only 2 to 10%. So CRPC is a lethal disease. Patient is going to die. So how the treatment is selected based on this? So for a localized prostate cancer, so you have 3 options. Either you go for a surgery or a radiotherapy or watchful waiting or active surveillance. Now, if you have 3 options for a given patient, how you are going to select a given option? That will depend on so many factors, patient-related factors, and the disease-related factors. When we talk about patient-related factors, the life expectancy should be more than 10 years. I often ask my residents, why do you take 10 years life expectancy should be there? What is the reason for that? Now, in the trial, it has been found that if you don't treat all these patients localized prostate cancer up to 10 years, that means whether you operate, whether you go for a radiotherapy or whether you go for active surveillance, up to 10 years, there's no difference in survival. After 10 years, the difference is probably seen, because if you have operated, they are going to live longer. If you have not operated, they are not going to live longer beyond 10 years. That's why this criteria of if the life expectancy is more than 10 years has come into place. So now how we are going to select operate or radiotherapy or watchful waiting? That will be depending on the patient's choice, patient life expectancy, as well as the patient's preference and the compliance of the patient, and some sort of aggressiveness features of the prostate cancer. Say, for example, patients localized disease 3+3. Normally, these patients can be put into active surveillance or watchful waiting. Watchful waiting is totally different. Watchful waiting means you don't want to treat them actively. This is a palliative treatment. Unless and until the patient becomes symptomatic or metastatic, you don't treat them. But active surveillance, you are not denying treatment. You are telling him to give the active treatment, but you are delaying it. Why? The treatment has got side effects. Say, for example, you go for a radical prostatectomy. The two common side effects related to the surgery is that incontinence and sexual dysfunction. So if you can delay it for 10 years, at least patient can enjoy his sex and can have a continence. So why you want to give this thing? So if you delay it for 10 years and that point you go for a surgery, the survival is similar. So this is the concept of active surveillance. So that means there is a time limit from where you have to say, no, it is enough, now you have to go for active treatment. So how do you go for active surveillance? You have three things in your hand. One is clinical examination by DRE, second is PSC, and third is MRI and biopsy. Now, you have to call the patients every 6 months for PSA, annually for DRE, and annual, then 1.5 years or 2 years, every 2 years for this MRI, and then go for a biopsy. Now, if there is a change in biopsy, upgradation in biopsy, then only you change the treatment. Rather than active surveillance, you go for active treatment. So this is most important. Not only based on MRI findings or PSA findings, you don't change into active treatment. That is the active surveillance. So who are the patients who can go for active surveillance? So very low risk as per NCCN or a low risk EAU, they can go for active surveillance. But not all low risk patients will be a candidate for active surveillance. So how to classify? There are some patients who are really aggressive, though it is 3+3. You are making decision based on your pathologist criteria. You go for a genomic test. That is called tissue-based genomic test. There are 5 commercially available tests are available. There is a Decipher POTOS, Oncocyte DX, Genomic Prostate Score, and all these genomic tests, they try to see whether these patient, though it is 3+3, whether it is aggressive or not. If the genomic test is positive, then most probably he is not a candidate for active surveillance. He is a candidate for active treatment. So that is a Decipher score, just telling you how to do the Decipher scores. This is a genomic testing which is available in the market. Now, other treatment is radical prostatectomy or radiotherapy. The radical prostatectomy, where we remove the prostate and the seminal vesicles as well as the lymph node. Whole prostate is removed along with the seminal vesicles. Now, this radical prostatectomy can be done by open surgery, by laparoscopy, or by robotics. In PJ, we are commonly doing it with this robotic surgery, because that is the surgery should be done by robotically. Because of this is not, may not be for the patient's sake, this is for the surgeon's sake, because the anastomosis, doing an anastomosis in the pelvis is very accurate if you use the robots. There's no study which says that the oncological, whenever you talk about these 3 modalities, you are talking about an oncological outcome and functional outcome. No study can say the oncological outcome is better with robot. Most probably it is similar with the open surgery, provided the surgeon is good. So it is depending on the surgeon rather than the modality what you are going to use. But there are certain advantages of robotics, which we all know, that less hospitalization, less complication, less blood transfusion, and less, definitely blood transfusion related complications will be less. Early continence may be better, but oncological outcome is similar. Or you can go for radiotherapy. So definitely radiotherapy is not my field, but if the outcome is similar with both surgery as well as radiotherapy, then how we are going to counsel the patient? It will be a patient's choice. You go to the radiotherapy department, they will counsel in such a way so that patient is convinced for radiotherapy. But usually age is the criteria. Patient, surgeons are a little bit opportunistic. If the patient has got comorbidities, most probably they will not go for or pay for the surgery. They will send the patient to the radiotherapy. And the radiotherapy, we have 2 types, either external beam radiotherapy or the brachytherapy. Now, external beam radiotherapy may be IGRT, IMRT, because now see, we are telling as a surgeon that our surgical technique has improved. The radiation oncologist also will say our radiation technique has also improved, like IMRT and IGRT. So they can precisely, whenever you're talking of any treatment, efficacy and toxicity, because radiation therapy has got toxicity. Now, because they have modified their technique, their GI and GU toxicity has improved. That's why they said, yes, okay, we will go ahead with this thing. Now, whether to go for external beam radiotherapy or a brachytherapy or a combination of therapy, it will all depend on the risk. So a low risk patient, maybe you can go for brachytherapy. If it's a high risk patient, external beam radiotherapy plus brachytherapy combination. It is their field. Most probably I should not talk much about this, but what I can say that both the treatment modality gives more or less equivalent oncological outcome. Only the side effect profile is different, and it's a patient's choice what to take. And whenever you go for a radiotherapy, patients will be given combination therapy. That's what I'm telling. We are in the era of combination. Combination for a diagnostic purpose, combination for therapeutic purpose. When you go for a radiotherapy, you have to combine this thing with ADT, hormone therapy. Now, after you have done radical surgery or radiotherapy, patient may come back. When you counsel the patient that 1/3 of the patient after radical prostatectomy, even if the surgical margins are negative and the PSA is less than 0.02, they will come back within next 5 years with the raised PSA. That is called biochemical recurrence or BCR. And you do all investigations, you will not find anywhere any cancer, but PSA is red. This is called biochemical recurrence. And the definition of biochemical recurrence following surgery and following radiotherapy is totally different, because in a radiotherapy, the benign prostate tissue is still there. So your PSA will be high. So the successful surgery, the outcome is PSA at the end of 4 to 6 weeks after surgery is less than 0.02. If it is going up, that means there is a biochemical recurrence. And in a following radiotherapy, it is 0.2. Now it is going up, that is a biochemical recurrence. And whenever there is a biochemical recurrence, then you have to restratify. Again, I said that every stage of the disease, you have to restratify the patient. Even in biochemical recurrence, you restratify whether patient has got low risk or high risk. What is the idea? What is the worry about the patient? Because as we told, the survival for a metastatic disease is very low. Survival for CRPC is very low. So we don't want, the patient doesn't want to have a metastatic disease. And these patients with BCR, they will develop metastasis. So to prevent the metastasis, we have to go for a therapy. Now, how to select? Then we go for a PSA doubling time. If the PSA doubling time, so as you go in the later phase of the journey of the patient, we basically rely mainly on PSA doubling time rather than PSA absolute value itself. If it is less than 12 months, most probably it's a high risk. If it's more than 12 months, it's a low risk. For a high risk patient, you have to go for a therapy, and usually we go for ADT, and that is it's a dual therapy, ADT plus ARPI. Now coming to a metastatic HSPC, I told that metastatic HSPC patients, again you have to restratify. How do you restratify this patient? Based on how much is the metastasis. It's a high or a low volume by Chetard criteria. If more than 4 metastasis is there, and that should be 1 outside the vertebral column, it's a high volume disease, or patient has got a visceral mets. So I told, in a metastatic disease, always for a clinical purpose, whether the patient has got bone mets, lymph node mets, or visceral mets. If patient has got visceral mets, irrespective of the volume of the bone mets, it's a high volume disease. And if it is not, then it's a low volume disease. In a latitude classification, they call it a risk, high risk versus low risk. High risk, if more than 2 risk factors are there, that means more than 3 bone metastasis or a visceral metastasis or ISUP grade 4. If 2 out of these 3 are there, it's a high risk. So that's how you decide what should be the treatment of choice. I'll tell you, there are so many treatment modalities available for metastatic HSPC, and how to select based on this risk stratification. And one area is called oligometastatic disease. Oligometastatic disease is very low volume disease. So how we are going to choose? It will depend on patient-related factors and disease-related factors. Disease-related factors like disease burden, we have decided, stratified, whether it's a high volume or low volume, high risk or a low risk, or a histology. Pathologists also come to play in this decision making. If the pathologists say, rather than acinar adenocarcinoma, patient had neuroendocrine tumor or patient has got intraductal tumor, most probably they are not the candidate for ADT or hormone therapy. They need chemotherapy. So that's why pathologists has a role to play. The nuclear physicist has a role to play, and of course, as a clinician, you have a role to play. You are supposed to check the patients, what is his life expectancy, what are the comorbidities, what is his performance status, whether you go for you have to assess the performance status for any patients with malignancy, and cognitive function, nutritional status, and of course, the patient preference. Most probably, we don't talk about the patient's preference. So based on this patient factor, disease factor, and histological factor, you decide which one you to go. Now, before going to the hormone therapy, we should just for revision of our knowledge in hormone. So what happens from the hypothalamus? LH, RH is secreted, which stimulates the pituitary to produce LH or ACTH, and that LH will stimulate the testes to produce testosterone, or ACTH which stimulate the adrenal cells to produce androgen. So androgen source in the body are either from testis or from the adrenal, and all those androgens will go to the prostate and they will be converted into dihydrotestosterone. The dihydrotestosterone is the active androgen in prostate cells. Now this slide is very important. So you see there are 3 stakeholders. One is the testosterone itself. So whenever talk about a therapy, there is a testosterone. There's an enzyme which converts this testosterone to dihydrotestosterone, and this dihydrotestosterone combines with a receptor. So ADT, that's the ligand, the enzyme, and the receptor. The receptor and ligand combined, they go to the nucleus and they get attached to the DNA and produce the mRNA for production of protein, production of the function. So these three are important. So whenever you are removing the T, that is called ADT. When you are this is the adrenal signaling. That means when it is attached to a receptor and goes to the nucleus, if you modify this pathway, it is called adrenal androgen signaling pathway inhibitor. So that's why you should remember this slide very well. So what are available in our hand? You have LHRH agonist. How does LHRH agonist do? They usually stimulate first and then sustained level of LHRH agonist will produce less and less of LH to produce less testosterone. The whole purpose of this hormone therapy is to have a castrated level of testosterone in the blood. Whether you are going for LHRH agonist or antagonist. In the antagonist, they immediately act because they are going to bind to the receptor for LHRH and then they reduce the production of LH and testosterone. So that is the difference between agonist and antagonist. So you have both agonist and antagonist. Basically, you have three options: orchidectomy, estrogens, and this LHRH agonist and antagonist. Orchidectomy for poor patients who cannot afford. It is cheaper, and within few hours, the testosterone level will come down to the castrated level. So it is quick response. LHRH agonist and antagonist. Agonist will produce little bit of testosterone, higher testosterone in the initial phase. That is called biochemical flare. And after that, about 4 weeks, the testosterone level will come to the castrated level. On the other hand, antagonist within 3 days will produce castrated level of testosterone. There is the difference between agonist and antagonist. Now, what are the antagonists available? Is Degarelix or oral is Relugolix. Relugolix has not yet come to our market in India, but Degarelix is available. Now, how to choose whether you want to go for agonist versus antagonist? Now, there are 3 areas where most probably antagonist will be very helpful. Say, for example, if the PS volume is very high, PS is more than 20, that means it's a huge prostate cancer volume, then antagonist will work better. Patient has got a large bladder outlet obstruction symptoms. Patient might go into retention. Patient ureter can get obstructed. There it acts nicely. Or a patient has got say for example spinal cord metastasis. You want to work immediately, quickly. So there are the few indications where you have to go for antagonist. Another indication, people say that these LHRH agonists, they usually cause cardiovascular morbidity and mortality. But if we use antagonist, most probably it will be less. So you have both agonist and antagonist, you have to decide. Now ARPI, if you remember that slide, ARPI, the androgen receptor pathway inhibitor. What are those drugs which are available? That is the abiraterone, enzalutamide, and apalutamide. Abiraterone, of course, it is not the pathway inhibitor. It reduces the production of androgen from the one's prostate cancer cell itself, as well as and the adrenal. It is a CYP17 inhibitor. So abiraterone, when you give, there will be no production of testosterone, but there will be increase in ACTH production. Because of the increased ACTH production, there will be mineralocorticoid excess, and that is the reason for its side effects like hypertension and fetal edema. That's why you have to give prednisolone. So whenever you are prescribing abiraterone, always prescribe prednisolone. So this is not a urology talk, so I cannot explain everything. And then enzalutamide and apalutamide, they are basically the true ARPI. Then you have chemotherapy in your hand, either docetaxel or cabazitaxel. So what you have for metastatic HSPC, you have ADT, you have chemotherapy, you have ARPI. Now, before 1980s, only ADT was the drug of choice. After that, all these drugs, chemotherapy had come, docetaxel had come. So then 2004 onwards, docetaxel has been given for CRPC, but before that it was given for HSPC. So docetaxel used to be given for CRPC. Now it is being switched over to HSPC. Now, if you have all 3 modalities of treatment, you go for combination therapy. People say, why to wait for the patient to go into CRPC? So you are switching over the drugs of CRPC into HSPC. That's why nowadays nobody goes for a monotherapy. Again and again, I am emphasizing, today's era, metastatic hormone sensitive prostate cancer, you have to go for a combination therapy. That combination will be either by 2 drugs or 3 drugs. Commonly ADT plus chemotherapy, or ADT plus ARPI, or a triple therapy, all 3. Now, how you are going to decide? Again, how you are going to decide which combination should be given? It will all depend on the volume. That's why you have risk stratified. For a patient with a high volume disease, it has been found if you add chemotherapy, it is going to give survival benefit. Any drug will be FDA approved unless and until there is a survival benefit, it is not going to be approved. So if you add chemotherapy to a high volume disease, it has got survival advantage. But a low volume disease, it is not there. So there are several studies which are available, and to say that ARPI also, if you add to ADT, it improves the survival. Like docetaxel, it was seen in Chartered and Stampede trial for abiraterone, latitude and Stampede trial again, and enzalutamide by Archie's and Enjamate, and apalutamide Titan trial. So 3 drugs apart from chemotherapy can be added to patients with MHSPC, that is abiraterone, enzalutamide, and apalutamide. Now, how to choose among these 3? Abiraterone, enzalutamide, and apalutamide, it is to be the question. See, the abiraterone had come early, 2017, or it's before enzalutamide. So people usually use abiraterone. And if the patients are not responding to abiraterone, they are using enzalutamide. That is not abi-enza. Now this sequence is not supposed to be effective if the patient, because their mechanism is same. So you have to decide based on the side effect profile. If the side effect profile is different and patients are like enzalutamide, it doesn't produce that sort of a pedal edema, it doesn't require prednisolone. But enzalutamide has a specific side effects of developing seizures. So patient who has got a history of seizures or a low threshold for developing seizures, you should not prescribe enzalutamide. You go for abiraterone. So these are the studies. I don't think it is required, just to prove that yes, based on all these RCTs, these drugs have been approved by FDA to give a combination therapy for metastatic hormone sensitive prostate cancer. But what we are gaining, that's what I told in the beginning. The actual median survival for a patient with metastatic hormone sensitive prostate cancer used to be 3 years before these drugs came into the market. Now it is going to be 5 to 6 years. So actual gain is not that high. So death reduction is by 12%, 20. You can see this chart. So it's 61% in only Enja plus ADT. So if definitely when it becomes metastatic, it is really, really incurable. You cannot cure those patients. And these are some studies which says that for a high volume disease, you go for chemotherapy. For a low volume disease, or both high and low, you go for abiraterone or enzalutamide or apalutamide. These are the studies. I am not going to talk much about that. So any patient where you have not given any hormone therapy, now patient has got a metastatic disease, you have 3 options, either docetaxel, enzalutamide, or abiraterone. Only ADT is not the option. ADT has to be combined with one of these 3 drugs. That improves the survival. Now, how we are going to assess the patient after giving a therapy? Usually, we call the patients after say 6 weeks or 3 months and see the PSA response. If the PSA response in one study says at the end of 7 months of this therapy, if the PSA is less than 0.2, the most probably survival, median survival will be 75 months. If the PSA is 0.2 to 4, 43 months, if PSA is more than 4, that means not that 99% of the patients will respond to this ADT therapy, but this therapy may not be optimum, or it may not be there for a longer time. Now, who is going to tell us whether this particular patient needs or is going to go to CRPC early or not? It will all depend on this PSA response. If the PSA is more than 4, that means this patient is not going to live longer. So after starting hormone therapy, patient was doing well, PSA was controlled. Now PSA started rising. Then we call it a CRPC, castrate resistant prostate cancer. Initially, we used to call it hormone resistant prostate cancer, HRPC, but we call it a castrate. What is the difference between that? Castrate means castrate level of testosterone in the blood. That means you take a sample, blood sample for this patient, go for a testosterone level, and it is in the castrate level which is less than 50 nanogram per ml. But those cancer cells, within the cancer cell, they have higher level of testosterone. So they are producing testosterone itself. So that's why though patient blood level is at castrate level, testosterone is castrate level, but inside the cell, testosterone is high. That's why the name has been changed to castrate resistant prostate cancer rather than hormone resistant prostate cancer, because hormone is still there within the cell. Now, CRPC, there are 3 criteria. There are different guidelines, is different criteria, but EU is different. But normally what we follow is the EU guideline. So first and foremost is you send a sample for testosterone. It should be castrate level, and there are 2 progression. One is biochemical progression and another is clinical progression. So whenever you're treating with these patients of CA prostate, what you have? You have either PSA level or this imaging. So PSA levels should be rising. Now, how much is the rise? It's a rule of 2. PSA should be more than 2 nanogram per ml after 2 consecutive in case higher than 50% in at least 1 week interval. So you have to have 3 PSA values and they will be rising in PSA values and should be more than 50% of the nadir value. So when you given the ADT, what is the nadir value, you should know. If it is more than 50% and 2 times, then it is biochemical progression. What is the clinical progression? Again, the rule of 2. If you have 2 new metastases on the bone scan, or you have one bone scan positive, another soft tissue positivity, then it's a clinical progression or radiological progression. The NCCN says clinical progression like patient's pain has increased. That is a clinical progression. They call it a CRPC, but that should not be called a CRPC by EAU. EAU guideline says that it should be a radiography progression or biochemical progression. Now, how we are going to treat these patients of CRPC? The problem is whatever drugs like docetaxel, abiraterone, enzalutamide, whatever was the drug for CRPC earlier. Now, of late, we have switched over all these drugs in the HSPC stage. So you have nothing much left here in the CRPC stage. Now, but there are some principles that it should not, monotherapy doesn't work much. It has to be combination therapy, or it can be sequential therapy or a precision therapy. I will talk about precision therapy later on. So what is the survival or see metastatic CSPC 12 to 15 months gain in survival? M0 CRPC. What is M0 CRPC? I'll talk later on. M0 CRPC and MCRPC. If you see whatever drug you are giving, it is not improving that much, only few months or maximum a year and a half. That is the actual gain in life, whatever drug we give. So what are the goals? Goals is improve the overall survival, of course, progression-free survival, and reduce the risk of emergencies. What will happen? Majority of the patients are having a bone metastasis. So they will have a bone-related SRE, skeletal-related events, either fracture or patient can have increased bone pain, or patient may require some surgery for that or a radiotherapy for that. And that is called SRE. So you have to take care of the bones also by other than oncological drug. And patient obstruction can be have obstruction in the urinary tract. So this is the problem of CRPC. So patient can die because of ureteric obstruction leading to uremia. Patient can go into retention due to obstruction. Patient can have a spinal cord spinal column metastasis leading to spinal cord compression leading to paraplegia. So you have to prevent all those things. So you have to take care of the cancer. So there are 3 aims of these patients for treating these patients. One is cancer control by the drugs, and bone health and quality of life. So I think I had discussed all these things, how the hormone works and what is mean by castration and from where it is coming. So this is a castration resistant prostate cancer. So you have removed the testicular source of androgen. So one source of androgen is left, that is the adrenal. So that is when you give abiraterone, it usually reduces the adrenal source of androgens. But in the cells, the intertumoral steroid synthesis takes place, and that can give rise to this sort of progression of the disease. Not only that, the receptor which is supposed to go and bind to this DNA and produce the protein or mRNA and protein, that may be defective. So there will be mutation of this part of the receptor. This receptor has got different components. I'm not going to the details of it. The commonest mutation or commonest variation is ARV7. That means if the receptor is defective, so whether the androgen is there or not there, it is not, so it is not going to be effective. So that is, if you have, suppose you have given, that's why I said more than 90% of the patients after giving ADT, they are going to respond. If some patients are not responding or not at all responding or not minimally responding, then you have to suspect that most probably their receptor is defective, and there you go for this study, ARV7 mutation. And how to study that? Either you can go for a genome sequencing study, or commonly what is being done is IHC, immunohistochemistry. In the prostate cancer specimen, you go for IHC and then see whether ARV7 defect is there or not. So those patients are not responding. Now patient had responded, has again rising PSA, that is you are dealing with the CRPC, then what are the drugs available? Now we have few drugs available, first line, second line, third line, and the newer drugs. The first line, again, the chemotherapy may be docetaxel or ARPI, abiraterone, enzalutamide, or Sibulacel T, which is actually what we do. You take the sample of blood from the patient, take their monocytes, expose them to some antigens, make them effective, and then switch them back to the patients, and they will be effective. Sibulacel T is not available in India, and because it is a tedious job to take this thing, and normally it is given for a patients who are asymptomatic or minimally symptomatic, and there should not be visceral metastasis. That's why I said whenever treating a CA prostate metastasis, CA prostate, you see whether you are dealing with only bone, only lymph node, or visceral metastasis. Any visceral metastasis, chemotherapy is really the drug of choice, not the other things. So similarly, sickle cell T is not the drug of choice if the patient has got visceral metastasis. Second line, again another drug is chemotherapy is cabazitaxel. Then you can ask why cabazitaxel is giving as a second line. It can be the docetaxel. Both of them are taxane, but it has been found that it really doesn't work in the as a first line. But in the second line, it works, and side effect profile is too much compared to docetaxel. That's why. So whenever we choose a drug, you see the efficacy as well as toxicity profile. If toxicity profile is favorable, go for it. Third line, again the chemotherapy is cabazitaxel. Again, abiraterone and enzalutamide is a third line drug. That means a patient who had received docetaxel first, you can go for abiraterone or enzalutamide. Or a patient who has received abiraterone or enzalutamide, you go for cabazitaxel as a second line or third line drug. Now the problem is today all these first line, second line, and third line drug has been switched over to the MHSPC, metastatic hormone sensitive prostate cancer. Then what is left? We are left with only 4 drugs. That is a PD-1 inhibitor, pembrolizumab, platins, that is the cisplatin, or this thing PARP inhibitor, and radioligand. So basically 3 drugs I can say: PD-1 inhibitor, that's an immunotherapeutic drug, PARP inhibitors, and radioligands. What are those drugs? I'll just go one by one. Pembrolizumab we know, and it is being tried. How to now select? In this you have 4 options or 3 options how to select. Now here comes the precision medicine. Precision medicine means if the patient has got some genomic abnormality or variation, mutations, then you should go for PARP inhibitors. What was this? Normally when a cells divides or any normal cells, there will be some damage in the DNA, and cell has got a DNA damage repair mechanism. I'll come later on. The DNA damage repair mechanism. If the DNA damage repair mechanism is damaged, then the cell will not be able to proliferate, and it is going to go for apoptosis. So if the PARP enzyme is the enzyme which helps for repair. Now, if you inhibit that enzyme, most probably the cell is not going to repair itself. That's why PARP inhibitor role is there. Now, in a genomic study, it has been found the patients with metastatic CRPC, about 25% of the patients will have this genetic abnormality. That genetic abnormality can have either HRR, homologous recombinant deficiency, or MMR, mismatch deficiency. Because why do you want to know this? If it's HRR, that means, see, we name the genes. We have 30,000 genes. Genes are being named. The commonly named genes for prostate cancer is BRCA2, BRCA1, ATM, HOXB3, 13, or HRR or MMR genes like MSH, MLH. All those genes are named. If these gene mutations are there, that means HRR gene mutation, PARP inhibitor is going to work. If MRR gene mutation is there, PARP inhibitor is not normally going to work. That is to work by this thing, the PD-1 inhibitor, pembrolizumab. And the radioligands, we have 2 radioligands, that is the radium-223 or lutetium PSMA. Another radioligand, which is lutetium actinium, this actinium PSMA. They are very effective. So essentially, you have 3 drugs in your hand. So how to select? Again, to select a particular drug, that will depend on patient-related factors like performance status, life expectancy. As I told, only few months or maximum 1.5 years you are going to give the life to that particular patient. So it will all depend on the life expectancy, comorbidity, and the disease-related, what is the extent and histology. Like a patient who has got interrectal histology, so most probably these drugs are not going to work. The ADT is not going to work. The previous treatment, what was used before going to the CRPC, and the genomic profile. And this is the timeline of development. So why I said that why abiraterone is being preferred, because it came into the market before enzalutamide. Otherwise, if you ask me what is your drug of choice, I would prefer enzalutamide than abiraterone, because abiraterone you have to give prednisolone also, and prednisolone produces, I mean, it deteriorates the sugar level also. So a patient who is diabetic, who has a cardiac abnormality, they are contraindicated. But enzalutamide is contraindicated where the patient has got seizure. So you decide the drug based on side effect profile. Then you go for a combination therapy. So what are the combination you can go for it? So I'll just go through these slides. Again, I'm telling the same thing. See, based on these trials, these drugs have been recommended for treatment in CRPC patients, but the gain in survival only in few months. Again, these are the trial like TAX 327, Preval trial, COU 302, Tropic trial, CO trial, AFAM trial, Assemblyca trial. So all these trials they have tried for a combination. So this is the era of combination. But even with this combination, the survival is not very good. Now, combination therapy and sequential therapy. Initially, when this combination therapy concept did not come in the CRPC patient, used to go for a sequential therapy. So, a patient who has recurred or who has gone to CRPC after ADT, go for a docetaxel. After docetaxel failure, you go for this ARPI. Now we go for a combination. What is the combination? Abiraterone plus ipatasertib. What is ipatasertib? That is the AKT4 AKT inhibitor. So that is the signaling pathway inhibitor. So that can also be used, and it has been found that if you combine these drugs, most probably it is going to work better. Even with olaparib, that is the PARP inhibitor, along with abiraterone, it has been found that it gives some survival advantage. So, but we know that ultimately all will progress. Cannot combine the drugs because of toxicity except abiraterone, ipatasertib, and abiraterone and olaparib. What about a sequential therapy? Nowadays, nobody talks about a sequential therapy, but still, only few years here, combination therapy for MHSPC has come. So that's why still sequential therapy has to be discussed. Most of our patients used to take only monotherapy. Now they have come with the CRPC. You have to go for a sequence. So what should be the sequence? If the patient is on ARPI, better not to go for another ARPI. If the patient is on ARPI, you can better go for PARP inhibitor. If the patient was on docetaxel, you go for a docetaxel rechallenge if the doubling time is more than 20 months. If the patient was on ARPI, go for a docetaxel, then ARPI followed by PARP inhibitor. This is the best sequence where you can give that to the patient. So again, next is precision therapy by molecular selection. That's what I was talking about. So genomic profile, it should be either you study the single gene or a multiple gene. Commonly, it should be multiple gene. There are two types of genes I told, HRR and MMR. HRR BRCA1, 2, ATM check 2, HOXB3, and these are all tests are available. Because that is going to tell, rather than giving so many other chemotherapy or immunotherapy, which is not going to work. If you go for this genomic study and it says that this patient is going to respond, so you're going to go for a PARP inhibitor. So that is the precision medicine. So this is the best slide, what I feel. So a patient who has progressed, so you go for PSA doubling time. If PSA doubling, say patient who was on docetaxel, he has progressed, then you go for a PSA doubling time. If the PSA doubling time is less than 12 months, in 1 year, that means they are not going to respond to docetaxel again. You go for a cabazitaxel. If it is more than 20 months, you can go for a docetaxel rechallenge. And if it is in between 12 and 20 months, then doubling time is less than 3 months, go for a cabazitaxel. If it is more than 3 months, abiraterone and cabazitaxel. What I mean to say, how to remember all these things. So any patients in the later phase of their disease, go for a combination therapy and decide the treatment based on efficacy as well as toxicity profile, and change the drug based on the PSA doubling time rather than PSA absolute value. Now, M0 CRPC. What is the common example of M0 CRPC? Like, I still remember when I was a resident, any patient with CA prostate used to come, the treatment used to be bilateral orchidectomy, irrespective of the stage of the disease. Very few centers used to go for radical prostatectomy or other therapy. Now, the patient who was non-metastatic to start with, and you have done bilateral orchidectomy. Now, it will be there, patient will respond to this orchidectomy for maybe few years, 10 years or so. After that, they will come back with rising PSA. And you go for radiographic study and you find no metastasis anywhere. So that means patient has got M0 status, but PSA is rising. That is the M0 CRPC. Now, what is the philosophy of treating these patients? Now, these patients, if you don't treat, they will develop metastasis in the bone. And if they develop metastasis, the survival is poor. That's why you have to prevent. That is why we talk about metastasis-free survival and overall survival for this patient. And different studies have shown that 3 drugs, Spartan trial, Phosphor and Aramis trial, it has shown that apalutamide, enzalutamide, and darolutamide can improve the survival, and they can prevent them going into metastasis. And the best drug is darolutamide because it shows some survival advantage. So what are the other markers? ARV7 I have already told, genomic markers I have told, and other markers is PD-L1 status, MSI high, that is a microsatellite instability high or tumor mutational burden. If these are high, very high tumor mutational burden or MSI high, the platinum or pembrolizumab is going to work. So if we see, we have 20,000 to 25,000 genes, and these genes may be damaged or may be altered. Now, whenever there is a DNA replication, sometimes there may be damage of the DNA, and this DNA damage may be either double strand damage or a single strand damage. If it's a double strand damage, then we need a repair mechanism that is called HRR, homologous recombination repair. If a single strand damage is there, is called, if there is some problem, it's called MRR, MMR, mismatch repair damage. So if these genes are positive, or there is a mutation on these genes, most probably they will produce a defective protein which will be responsible for failure of this damage repair, and these patients or those cells will be responding to any PARP inhibitor, that is called either commonly two drugs PARP inhibitors available, that is the olaparib and rucaparib. There are other niraparib and other paribs are available, but commonly FDA approved paribs are olaparib and rucaparib. The cost of those drugs is about 30,000 per month. And the studies which had proven because of that this olaparib had come into the market is based on the PROFOUND trial, as well as, because there's no need to go through all these trials, and this Teton trial, Teton 2 trial. And based on these two drugs, that is the olaparib and rucaparib, have been approved for the treatment of this thing. So third category of drug for CRPC patients are the radioligands. Again, I had shown the same picture again. The PSMA, it has got three components. The outer component or extracellular region acts as an antigen. You produce an antibody, track that antibody with the radiopharmaceutical. If you are doing it for diagnostic purpose, you add gallium-68. If you are going for therapeutic purpose, you go with lutetium or actinium. So same antibody, just tagging with different radionuclide. So that will be used for both diagnosis as therapy. That is why it is called theranostics. And usually, and we in PGI, we give this lutetium PSMA, the patients who are not responding to other drugs for CRPC, and usually every 4 weeks it is to be given. And predominantly patients who have got bone metastasis, they respond better. And the common problem with this is bone marrow suppression. That's why anemia and neutropenia is very, very common. So precision therapy should be either PARP inhibitor, pembrolizumab, or platins and radioligand therapy, which is catching up. Thank you. Hello. Hello.
We are with you.
Oh, I thought total pin drop silence. So I thought
No,
maybe
everyone was muted because they should not cause disturbance. Host
Okay.
has muted everyone.
Okay.
So, yeah, welcome everyone. Once again. Suresh Kagalkar, are you doing?
Sir, please.
So I had tailor-made by presentation, because see, each and every, I have about 100 slides for each and every aspect of those. Say for CRPC, I have 100 slides. For MSSPC, I have 100 slides. So because see, as a neurologist, we want to talk about all the trials and how they are going to affect and all those things. So this is not the area. So that's why I just cut short all those slides and given just brief or gist.
Yeah, it was absolutely, that was the tailor-made for most of the audience were the practitioners, not specifically from urology department. Definitely, you have concised the exhaustive topic, sir. That was very nice of you. And anybody who wants to ask questions, the forum is open. And I have received a few questions through the chat box. Shall I go through, sir?
Yes, you can.
Yeah, is PSA recommended to all BPH cases?
It's a very good question, and I said yes. A patient who has come to your clinic, patient is not telling whether he has got a BPH or a prostatitis or a prostate cancer. I said in all three, say whenever a patient comes with LARS, you have to see whether it is from bladder or prostate or urethra. You first decide, and then prostate has got 3 pathologies. All 3 will give rise to raised PSA. Now, patient with BPH, when you are treating the patients, there are few things you have to know. You need to know the volume of the prostate, because if the volume of the prostate is high, you go for a combination therapy. Volume can be measured digitally as well as by ultrasound. But in addition, PSA value will give the volume of the prostate. So for a combination therapy, we need to have a PSA. And before you go for a combination therapy, you need to have a PSA, because when you go for a combination therapy with alpha blocker and dutasteride or finasteride, it reduces the PSA within next 6 months. So that means whose PSA is 6, actually his PSA is 12. So those patients needs evaluation. So that's why before starting combination therapy of VPH patients, you have to have a PSA value, number 1. Number 2, whenever you are treating a patient of BPH, what is the worry of the patient? There are 2 worries: whether I am going to go into detention or whether I need a surgery. This is called BPH progression. Now, BPH progression can be assessed by PSA values. If PSA is high, most probably these patients are going to go into detention or they will require surgery. So for BPH progression. And third is, if we are really having a combination of pathology, BPH along with prostate cancer. So many a time we see patient has got both. So that's why BPH patients, even if it is BPH, PSA has got a value. So there's no confusion about it. We are not talking about a mass screening in the community. We are talking about the clinic screening. A clinic patient has come with LARS. You have diagnosed BPH, still there is a role of PSA, because if you want to start combination therapy or you want to tell the patients about his progression. So answer is clear. You have to get the PSA done. It is just like a sugar level, isn't it? It costs down to 500 rupees. I think I'm clear in that.
Thank you, sir. So one more question. After digital rectal examination, should we wait for some time to do PSA?
Yes, it was initially thought of it that for after digital examination or after sex, I mean after ejaculation or after prostatic massage, after biopsy, we should wait for some time. But it has been found that the rise is not very high. Suppose a patient has got a PSA, say for example, after DRE also, patient PSA is 50. Hardly matters whether you have done DRE or not. But ideally, you should wait for 24 to 48 hours for the DRE. But to be very frank, practically, it is, if it is a borderline high, then it is a problem. Otherwise, ideally, as theoretically, okay, 24 hours, you should wait, 24 to 48 hours. But it doesn't matter much in day-to-day practice.
Yes, sir. Thank you. And this one more question, not related to urology, but people were very appreciative about your slides. About your slides.
Okay.
And, they've asked very nice presentation, sir. Can you give us a tip about where the slide design is available? Beautiful slide.
It is available everywhere. You see, you go to the this thing, Apple, and Apple Store has got so many things.
Yeah. I think we can add any templates to background.
Okay. Yeah. If you want, I can mail Dr. Suresh, and then he can distribute it. I don't have any problem, any issue with that. I'll be very happy if somebody.
So, the Oncotype D, how much it is costing, sir, for risk assessment?
To be very frank, yes. To be very frank, we are not doing here. These are all costly stuff. So this is what I told is theoretically, and it is available in India also. And many a time, most of the patients who are presenting in PGI, say for example, we are not, rarely we offer active surveillance. Any patient who has got a low risk or intermediate risk, rarely we get low or very low risk patients. That's why I told that these tests are done to decide whether patient of a low risk is actually a low risk, or usually there is a hidden high risk factor. Hidden high risk factor can be diagnosed by this tissue-based genomic study. That is, one is this, and this DECIPA study and all those things. So we are not doing it, to be very frank.
Yeah, it is costing around 2.5 lakhs. So
that's what I'm telling you. We are not doing it. Now there is one area like you have done a biopsy and biopsy is negative, PSA is high. There is several areas for the urologist to discuss, like high suspicion of prostate cancer, PSA high, and you have done a negative biopsy, what to do. So there all these studies help. Say then you go for urine-based marker like PCA3. then if there shows or epigenetic study, like whatever tissue you have got as a BPH, and if you see some epigenetic changes around that BPH nodule, most probably that patient has got a cancer. Because unless and until you do a biopsy or prove that histologically it is a prostate cancer, you cannot treat. So that means you have to take a decision whether you need to go for a repeat biopsy or not. First question. Second question, when you are going for a repeat biopsy, what should be the guidance, whether it will be MRI guided biopsy or PET guided biopsy. Commonly what we are doing nowadays, rather than MRI guided biopsy, we are doing PET guided biopsy. So patients who were trust guided biopsy negative, many of them with a high PSA are coming up with a positive biopsy when we are doing it PET guided biopsy. And this PET guided biopsy facility is not available everywhere. It's not available.
So thank you very much. Any other questions by the audience? Sir, any preventive measures?
That's what I was telling. So to be very frank, none of the, whenever you talk about preventive factors, that means modifiable factor. There are unmodifiable factor like age. As you age, you are going to develop prostate cancer, most likely. So you cannot prevent that. If you have a family history, that's why I told the hereditary cancer, family cancer syndrome, they're totally different. So if you have a history of cancer, prostate cancer, or whenever you take the history of prostate cancer, you see, we don't treat the patient only. You should treat the family members also. That means a patient who has got a prostate cancer, you go for a genetic study. If BRCA2 is positive or mutation is positive, you ask their female members also to test for that, because they are also at higher risk of developing breast cancer, ovarian cancer, pancreatic cancer, colon cancer. So genetic study is to be done at every stage, more or less. So genetic factor is there, you cannot prevent. Third is race. African descent, African American, they are at high risk. We are at a low risk. So these are unmodifiable factor. We cannot modify. What are the modifiable factor? Is your lifestyle. That is, if you have a metabolic syndrome, and it has been found that metabolic syndrome has got 3-4 components, but only one component is predominant, then they may be at a higher risk of developing prostate cancer. Second thing is diabetes. Diabetics are not at higher risk, but it has been found that rather, if you are taking metformin, most probably it reduces the risk. Then alcohol. Then people say that alcohol, very high intake of alcohol, it actually doesn't increase the risk of prostate cancer, but it increases the risk of prostate cancer related death. I mean, that fellow alcoholic, if he develops prostate cancer, he'll die early compared to non-alcoholic. So all these dietary factors, people used to say, that's what I told, that there was a study going on in Australia. There is a garlic. People say that selenium is there in the garlic, and most probably garlic prevents prostate cancer initiation. So their study, but at the end of the day, it was found that it really does not prevent this thing. Then, so tomato, lycopene. So people say you take a lot of tomatoes, most probably it prevents prostate cancer, but it's very marginal benefit. But one study says that if you take finasteride, one study was there, that is for the prevention study, that PTPC study, that says that if you take finasteride is usually given combination with alpha blocker, but we commonly use dutasteride. That reduces the development of low-grade cancer, but increases the incidence of high-grade cancer. So only drug which has been proven to reduce the prostate cancer incidence is finasteride. Otherwise, no drug, nothing, no dietary modification can help in prevention of the drug, this thing. Only thing, then what you should do? If you have a family history, you should go for early screening. In the journey of prostate cancer patient, you don't want to land into the stage of CRPC or HSPC, where life is only few years. So if you are detected at the early, your life is more. So those patients who need screening, that means you have a genetic history or family history, you have to screen. So if BRCA mutation is positive, they say at the age of 40 only you do, then at the age of 45, second PSA, at the age of 50, third PSA, then after that, every year you go for it. If your family history is positive, but BRCA2 mutation is not there, first screening should be done at the age of 45 PSA. It is normal, go for PSA screening, PSA level estimation at this thing. So not taking only one value, it has the serial values. So that helps you in prevention of the prostate cancer. You can say prevention of development of metastatic or lethal cancer, nothing else. So no preventive measures.
Yes, sir.
Thank you.
Sir,
Anything
sir.
related to masturbation? People talk so much about.
Yes, it's a very good question. It has been found that those people who ejaculate more than 20 times per month versus the persons who ejaculates 4 to 7 times per month, it has been found the less incidence of prostate cancer in patients who ejaculate more. So whether you masturbate or you have sex, you have to ejaculate. So it has been found, and there are some Chinese study, that if you go for a vasectomy, only one study that shows that it is associated with the increased incidence of prostate cancer. But subsequently, none of the studies said that yes, there's no risk for developing prostate cancer. So that was one point against going for a vasectomy actually. So definitely masturbation and ejaculation has got some relationship with this thing. So better prostate health, go for more ejaculation.
Sir, digital rectal examination has no place in a regular screening for normal individuals, like self breast examination. What is your opinion regarding this, sir?
No, but how can with digital rectal examination? You have to go to a doctor, isn't it? Nobody can do the self examination.
I mean, similarity. I'm telling. Now they tell that
No.
digital.
Dear. So what you are telling is one study, that is there are two screening trial, long and huge screening trial was going on. One is European country, another is USA. So how to screen these patients? So when we were talking about the screening, mass screening, the community, any elderly patient, you go for this study. So they had done DRE and PSA, and it has been found that DRE doesn't get anything to do with the screening. You cannot really detect early cancer by DRE. So
Yes.
DRE, if the patient comes to your clinic, definitely you have to put the finger in the DRE. And nowadays, what is happening? People come with the PSA report, and even the urologist, they don't put the finger. They ask them to go for a PSA. If PSA is high, then they try to put the finger. So PSA is a better indicator. When you combine DRE and PSA, chances of detecting cancer is high. So if you ask me, frankly, DRE should not be a part of screening for prostate cancer.
Yes, sir. Thank you. Sir, on behalf of IMA Karnataka State Branch.
Still, two questions are there, sir, here.
Dr. Deepa.
What are the side effects of actinium-225 treatment?
Actinium is still not available in India. See, that's what I told. So in a CRPC patients, we have 3 armamentarium. One is PARP inhibitor, 25% of patient will respond to that. Second is this radioligand, and third is your platins and pembrolizumab. These radioligands, you have 3, either radium-223 or lutetium PSMA or actinium PSMA. Now, actinium PSMA, it produces actually alpha particles, and lutetium PSMA, it produces beta particles. So that's why if it is an alpha particle, they cannot move further. That's why whenever it is produced, there only it stays there. So surrounding normal tissue is not being damaged. That's why side effect is less. And because it's a heavy particle, the efficacy is more. That actinium PSMA is not available so far in India. Trial is going on in Germany. I think in Australia also. So commonly what is being used is lutetium PSMA, and which is available in PGI also. It costs around 20,000 per cycle.
And Dr. Girish is asking whether PET guided biopsy in PGI is real time or cognitive.
I think it's a real time only. I have to check with them, but I feel it is real time. It is not cognitive. So, I'm not sure about that. Because we send the patient there and they do it. We don't go and check, to be very frank.
No, it is only I mean, like when is picked up more, that area they'll be targeting via CT guided, sir.
Sorry.
PET guided CT scan is only
cognitive.
In in a patient who has undergone PET CT under the CT or CT guided, it's like that.
Okay. Thank you.
So this role of proton and carbon addition.
Sorry.
Role of proton beam.
Suresh sir, there is a background sound, sir. Suresh sir.
So you're talking about radiotherapy question, isn't it?
Yeah.
So I am really not expert in that field. Whatever we think that radiotherapy, we have a totally different department. What do they do? What I was talking about theoretically. So what are the options available? And that's what I told, in a low stage disease, localized disease, you have both the options, and the radiotherapist will say, after chemotherapy, survival is equal as you do after surgery. So now there is a debate. So then how to decide? It is the patient's choice, and of course, life expectancy. Young patients will go for a surgery. So how to decide that you are young patients? That's what I said. Now surgeons are opportunistic. Young patients, no comorbidities, patient is fit for anesthesia, you go for a surgical treatment. Elderly patient doesn't want surgery, then you go for a radiotherapy, because radiotherapy has its also own complications. It is not maybe oncologically more or less efficacious, but it has got its own different types of complications, GI and GU toxicity.
Those complications are less with this proton beam and carbon particle radiation.
Okay.
This is supposed to be the best form of radiation. That's why I have asked about this point, sir.
Okay. What I know is initially people used to go for 3D CRT. Now 3D CRT has been changed in PGI, IMRT and IGRT. IMRT and IGRT, I mean, you just focus your beam towards the lesion only, or organ only. So other neighboring organs should be spared. That is what is the improvement. The way I say that my surgery has improved because of the robot, they are also telling their radiation also has improved, because they can deliver that dose to the organ of interest and spare the surrounding structure, so the toxicity is less. Now, how it is going to be done, IGRT and IMRT, it is their field. I really cannot elaborate on that.
Yes.
Madam?
Yes, sir. Yes,
you can
sir.
call it today. Yeah.
Yes, yes, sir. So, any remarks from you, sir? Madhusudan, sir?
Nothing.
Yes.
It was an excellent talk, a very concise talk on a very important and very exhaustive subject. He has made it very simple. Thank you, sir, on behalf of IMA Karnataka State Branch. Over to Dr. Geeta Doppa
Thank you
for her conclusive remarks.
Yes, so excellent talk, sir. And many of our delegates have joined online YouTube, and the recording of the program also will be shared to the people who have not been able to join, sir. It will be there in our website permanently, sir. So definitely your talk is going to be very helpful to all. Yes. Now I request Dr. Suresh, sir, to deliver the vote of thanks. Unmute, sir.
Thank you, madam. First of all, I should give thanks to our today's the program, the speaker, Dr. Uttam Mete, sir, who is the professor and head the Department of Urology, PGI Chandigarh. In his busy schedule, sir, he was an examiner for postgraduate in the various centers. So in his busy schedule, he has taken time and has accepted our invitation. And thank you very much, sir. It was enlightening talk, and it is a very vast subject. Though it appears like a small cancer, but it is a very common the cancer. Everyone, every physician and any specialist will come across the disease. Such a common disease. They are enlightened, very good, and we are opportunists that we are listening from the PGI Chandigarh, and it is very good topic. Thank you very much, sir. Uttam Mete, sir. Once again, I welcome you for the any after our IMA KSP talk in future also. And similarly, I tell thank you to our beloved president, Dr. Srinivas, sir, who has given opportunity to conduct such a good, wonderful program. Thank you, sir. And also, I must say thank you to Karunakar, sir, who is the Honorary Secretary of IMA KSP, and he's also joined, and it's wonderful. He has given opportunity. Thank you, sir. And also, I must say thank you to our treasurer, Dr. Vijay Sarthi, sir, who has joined the program. Thank you, sir. And also the chairperson of the today's our past IMA president, Dr. Masood Kariglur, sir, who has conducted very well for this program. And thank you very much, sir, Masood, sir. And I must say thank you to Dr. Chiniwala, sir, who has joined, and he's a president-elect. Chiniwala, sir, thank you for your joining, sir. And I must say thank you to Dr. Kumbar, sir, Dr. Harish Dalavant Bet, sir, Dr. Naj Madam, and also joined Dr. Vinay N. Madam. She has joined, and our beloved President of IMA KSB, past President Dr. Girish Nelvigi, who has joined and asked the questions. Thank you very much, sir, Girish sir, and Padma Prakash Madam, Divya Madam, and everyone who has joined, and all the urologists and the non-urologists and all the IMA KSP members, and everyone and also viewers who is a YouTube viewer. So everyone, I must say thank you everyone, and we'll conclude this program. And next month we will have a wonderful talk with a different speaker. Thank you everyone. Thank you, madam, and thank you all the.
I must thank for giving me this opportunity. Thank you very much.
Thank
We
you,
are
sir.
fortunate to have you, sir. Thank you very much. On behalf
Thank
of
you.
Bye bye.
Thank
Good
you.
night. Good night.
Thank you, sir.
Yes,
Thank
sir.
you.
Good night, sir. Good night, everyone.
Thank you, sir.
Thank you.
Thank you,
Good night,
Dr.
Good
Suresh.
night.
Thank you,
Yes,
Dr.
sir.
Deepa.
Yes,
Hope
sir.
to hear few more talks on very interesting topics from urology. We expect you from.
Always.
Yes, sir. Thank
I'm
you.
just call Sagar from Dr. Suresh whenever he calls me. Okay.